All right, so as everyone's coming in here, welcome everyone. This is another wellness webinar on our Thursdays. We call it Thriving Thursdays here. We have integrative medical professionals, health professionals, practitioners on here to talk about different aspects of health and wellness. Today, we're really happy to have on Dr. Variability Sheth, who is an MD. He's an integrative cardiologist, and he practices locally in Chevy Chase, Rockville, and Germantown. And he's going to be talking about integrative cardiology, integrative, and in terms of endothelial health, endothelium being the inner lining of the blood vessel, and endothelial dysfunction, and how we can really prevent and even ameliorate a lot of cardiovascular disease using an integrative approach. So really happy to have Dr. Sheth on today. Thanks so much for being on here.
Thanks for having me.
Yes, we're going to talk first about community updates, which we always do on these here, and we're going to talk about, I kind of put this on here because there is a lot of conflict going on right now. There's the pandemic, there's climate change, there's conflict overall, but there's collaboration between all these disasters. So one of the things we have to do is we know that we can try to take better charge of our health. And so unfortunately, though, the third wave of COVID-19 is now here. And this is a graph I took from the BBC, but the source is the COVID tracking project. So if you're ever interested in like how many cases or deaths there are, unfortunately, go to covidtracking.com. And this was actually taken at the end of October, where cases are about 60,000, but now we're up to about 150,000, I believe, new cases a day in the US, and we're about at 1,500 deaths a day. So we're close to the peak now of where it was in April for deaths, unfortunately. So hopefully that goes back down. But unfortunately, we're in the third wave now. And that Governor Hogan in Maryland and the Maryland Department of Health recently announced 48 hours ago that there's a travel advisory recommendation to avoid going to states with high COVID-19 case rates. So you see the highlighted states here. Most of the country is highlighted. The ones that are in purple are the ones that are, you know, safe to travel to without having to quarantine or getting a COVID test when you come back. So that is something that is now recommended by the state of Maryland, and you can see it right there. I just wanted to talk about this for a minute. I think a lot of people have been asking us about what are the future projections in 2021? Do we have to wear a mask for the rest of, for the rest of this year and the next year? What's going on with vaccines? So I wanted to take each of these pictures and just kind of talk about them for a bit. So I'm going to go with the upper left here, which is on Pfizer, and Pfizer has a vaccine. There's three major vaccines in phase 3 clinical trials right now, both with the two that I'm going to talk about. Pfizer and Moderna have 30,000 each, and they're Moderna is about to announce their results at the end of the month. And then Pfizer announced the preliminary results showing a 90% effectiveness rate for a COVID-19 vaccine, which is pretty good. The estimation was that the vaccine would be about 50% effective. So if those trial data hold true, then that's good for public health. It's good to try to, end the pandemic earlier potentially, but there is some issues with that too. There are issues with I guess we could call it compliance with getting a vaccine. There's is the vaccine in the real world with different people with medical conditions and everything gonna have the same effectiveness as in the trial? But that is the preliminary data is showing it's about 90% effective. In terms of when it's going to be available for people, I think the estimation is that it wouldn't really roll out till probably mid 2021 when you think about the different groups of people that need to have the vaccine, getting it to the clinics, needing to freeze the vaccine because it's like a deep freezer that's needed, and then because it's a booster shot, so you need like one, and then basically a month later you need a second booster. So with all that being said, we're really talking about mid 2021, which kind of goes back to in the middle here, we see a woman with a mask on. And part of it is I know everyone's tired of wearing masks, but I do think it's important to keep, public health-wise, social distancing, kind of reduce the spread of COVID. I think that the projection is that we may still be looking at wearing masks into 2021 because, there haven't been trials on kids, and kids still would potentially need vaccines. There have not been any data on kids under the age of 12. And there's just some very, very preliminary data on kids 12 to 18. So there's a lot more work to be done with vaccines. We're really not out of the woods with these yet. we want to be able to take charge of our health, really. And that's where the upper right comes in terms of, even with a vaccine, there's healthier people tend to have better responses to vaccines in general. People that have more sleep, less inflammation, they're going to have a better antibody response. They're going to have a better T cell response to viruses, whether it's a virus or a vaccine. And there are studies showing that the messenger RNA vaccine, like the Pfizer vaccine, does stimulate both antibodies from B cells, but also T cells. But healthier people are going to have a better response to vaccines. So it's still, we can't just focus on, we want to focus on masks and social distancing and vaccines, but we also want to not be totally dependent on them either, because we want to be able to augment our own health with healthy lifestyle, healthy diet, nutrition, exercise, etc., social connections that we always talk about on these webinars. And then, so I'm just going to go clockwise around this. In the bottom right, we talk about telehealth. And some people ask me, well, is insurance going to keep on covering telehealth? What's going to happen to the healthcare system in the future? I'd love to know Dr. Sheth's opinion on this. I think so far, knock on wood, insurance has still continued to cover telehealth. We're going to continue to cover it as long as we can. I think it would be it wouldn't make sense to not have telehealth available given the pandemic. So I think this will change medicine and have both in-person and more of a hybrid telehealth available for people moving forward in the future is probably what we're going to be looking at, which I think is a good thing, to have more access to care. And then another thing, this is sort of philosophical, and then I'll kind of go into the next slide, is that we kind of talk about the virus having a hold over the earth right now. You can kind of see what in that bottom left. And what have we learned from COVID? I think when we look back in a year or 2 years from now, what are we going to actually learn from COVID? And I would submit there's two things that we could learn, probably many more things, but one is humility. One is that we're not necessarily the dominating species on the earth, and can be or want to try to be, but we have to learn to take care of nature. We have to learn to be living in symbiosis with the rest of the earth here. And I think another is equality, is that we're not necessarily better than the animals that we necessarily kind of interact with. And in terms of people too, it's like we all think about how can we better serve each other, how can we be kind and compassionate to each other. So those are kind of some lessons I would like to just I don't know, that's something that I've felt that I've learned here. And if anyone else wants to share any thoughts about any of this slide, just type in the chat. I'm interested to see what have you learned from COVID and 2020, and hopefully moving into 2021. I just want to share this because, again, this has been a stressful time for everyone, obviously, a very unprecedented time. How can we cope with COVID-19? There are some mechanisms that the NIH has published. Take breaks from the news, take care of your body, make time to unwind, connect with others, both in person safely as well as online, and then set goals and priorities so you can manage your own health and kind of take charge of your health there, and that can and other goals you might have in life and priorities, and then focus on the facts. Right, there's a lot of news out there. What is kind of real, what's not real. So I think focusing on that and focusing on the science is what we always look at here too. So new practitioners, Stephanie is on here. Stephanie is our family nurse practitioner, new nurse practitioner that has had some experience in allergy clinic and training in integrative functional medicine, integrative primary care. So happy to have Stephanie here. It's been so helpful already. A lot of you have already met Stephanie Zamora. And then Ayla and Neil is actually both starting on Monday officially at Seeing Patients Monday. Ayla is a certified nutrition specialist, also trained in integrative functional medicine. So happy to have both Stephanie and Ayla here. And they are starting on Monday and taking patients, existing patients or new patients. And then Tony St. Clair Fish is also wonderful and amazing. She's a health coach. Let me see if Tony's on here. Anyway, we are doing group visits and we're doing round 2. Hey, Tony, I see you here. That's a shot got from the internet. So hopefully you like that shot there. Always look good no matter what. So health coaching round 2 is starting on Friday. So if you're interested in that, let us know. And then Elizabeth Reese is our heart math practitioner, and she is also amazing. And we do heart math, which you can talk about in relation to cardiology here, how to connect the heart and brain and increase coherence, increase heart rate variability. And we know that increased HRV also decreases the risk of sudden cardiac death and improves cardiovascular health. Excuse me. Drink some water. We have an immune visit coming up in a couple weeks that I'll be leading as well. Which virtual group topics would you like to see in 2021? So we have a bunch of cardiometabolic, brain health, heart math, gut health, nutrition, really a lot of things. Yoga, we're looking at too as a group visit, yoga therapy. Movement, so movement could be something we do with physical therapy. It's more of a structural, like if someone's back pain or neck pain, we can do group visits. Again, how do we provide more access to people? How do we be a better service to you? If it's not on here and you have a great idea, please write it in the chat. Or even if it's not a great idea, just write it in. Either way, they're all great ideas, really. But okay, so let's see. So we'll wait a few minutes to get the vote in. Joe's saying heart health, absolutely, yes. Hey Joe, good to see you here. Wendell's saying gut health, yes, those are always two of the top contenders for sure. And none of this is mutually exclusive. We're probably going to do a lot of these. I think the goal is to try to offer more community group visits, and there's something about the community as well that's healing when you're attending with others, you're participating with others, sharing in your health aspirations, health goals. There is a lot in regards to that. So brain health so far got more votes. Heart math, gut health. I think they're all relevant. I think we're all going to be, but and cardio is up there as well. Thank you. So today, Dr. Sheth will be talking about integrative cardiology and endothelial health, endothelial dysfunction. Last week we had integrative dermatologists on. Next week we're having a nutritionist on, Dr. Liz Lipsky, who is an expert in digestive wellness, which I know everyone here is interested as well. And then for Thursday, November 26th, we'll be enjoying a break and having Thanksgiving. So hopefully you enjoy that. 12 to 1 p.m. every Thursday here. So Dr. Sheth is a medical doctor, has an MPH, has a Master's of Science in Integrative Medicine, also from GW. He practiced for a long time in upstate New York, I believe upstate New York. It has more than 30 years of experience in cardiology, and shadowed here at CAH for a couple of weeks, and we loved seeing him there and getting to meet him, and just like we got to talk about integrative cardiology here. So thank you so much, Dr. Sheth, for being on, and I'll be handed over to you. Thank you.
Thank you. Let me get my screen. Hold on. My screen here. Can you guys see my screen?
No, not yet. You'll have to share first, I think.
Okay, hold on. So,
Yep, that looks like it's working.
can you see my screen?
Yep, that looks good.
All right. Hi. So my name is Sheth. I'm a clinical cardiologist, and I have an interest in integrative medicine. And the topic today is endothelial dysfunction. And I want to thank Andy for inviting me to speak. So we're going to start with a case study, which I will go over. And then I will also discuss the case, the different aspects of the case. And then I'm going to switch gears and get into the pathophysiology of endothelial dysfunction. And then we'll end with the different integrative and conventional approaches to treating endothelial dysfunction. So this case study is a 50-year-old woman. She presents feeling tired and stressed out. She's craving sugar, especially during these stressful times. She had an extensive integrative evaluation, and it revealed that she's flattened her cortisol curve. She's developed insulin resistance with elevated fasting blood sugar, 2-hour postprandial blood sugar elevation, elevated insulin, elevated A1C, and low vitamin D. She also has many of the traditional cardiovascular risk factors, in addition to diabetes, a strong family history, hypertension, and dyslipidemia. advanced lipid testing shows that she has an elevated LDL particle number, elevated oxidized LDL, low HDL, low ApoA1. She also has increased markers for vascular inflammation and oxidation, including increased oxidized LDL as well as hsCRP. She also has an elevated homocysteine, which is a marker for potential endothelial damage. And she has an increase in relative sympathetic tone with elevated resting heart rate, and she's also hypertensive. So this patient, if I were to put on my functional medicine hat, has an imbalance in triad 1, which is pancreas, adrenal gland, and the thyroid, most likely. She also has an imbalance in triad 3, which is vascular, brain, and cardiopulmonary, and I'll be going over that in detail. So in terms of vascular, I just need to minimize this here. Hold on. In terms of vascular, so the endothelium is a thin membrane that has a single layer and lines inside of the heart and blood vessels. And it's involved in maintaining homeostasis by releasing molecules that control vascular relaxation and constriction. And it also releases enzymes that control immune function, inflammation, oxidation, bleeding, clotting, and platelet adhesion. Endothelial dysfunction is a consequence of the cardiovascular risk factors, including smoking, hypertension with its shear forces, diabetes, dyslipidemia. The family history is important. And all of this results in reduced nitric oxide production from endothelial nitric oxide synthase, and also increased endothelin and increased angiotensin converting enzyme activity. The cardiovascular risk factors also increase oxidative stress. They produce reactive oxygen species, including as well as nuclear factor kappa B, which increases inflammation in the form of CRP. We get reduced nitric oxide, increased oxidative stress, and this causes vasoconstriction, platelet aggregation, hypercoagulability, smooth muscle cell proliferation, leukocyte and endothelial activation. These are all things that we see in the endothelium. Some of the clinical manifestations of endothelial dysfunction includes propagation of atheroma in the form of peripheral arterial disease, as well as erectile dysfunction in men. And we can also develop plaque rupture, which can cause acute coronary syndromes and strokes. We also see vasoconstriction, and finally we see leaky vessels in the form of microalbuminuria. Homocysteine in this lady probably would increase a reactive oxygen species, cause impairment in vessel relaxation, and production of protein damaging thiolactones. Also, her elevated small dense LDL and oxidized LDL have greater potential to form atheroma and vascular disease. Her obesity reduces her adiponectin, which increases her insulin and increases her insulin resistance, and increases her risk for systemic and vascular inflammation. And her chronic stress has led to a flattening of her cortisol curve, and which also leads to increasing inflammation in the form of IL-6 and TNF-alpha. She also has loss of sympathetic vagal balance due to chronic stress and anxiety. And as you guys mentioned earlier, it can lead to cardiac arrhythmias, platelet aggregation, coronary vasoconstriction. As you know, heart rate variability is a bidirectional interplay between the heart and the lungs. It's mediated by the sympathetic and the parasympathetic nervous system. And heart rate variability is basically the beat-to-beat variation in the heart rate that's seen on an ECG correlating to respiration. Emotions can affect heart rate variability. Anxiety and anger demonstrate a disordered pattern with increased heart rate and sympathetic dominance. Relaxation increases parasympathetic dominance, but really an appreciative and grateful disposition creates a smooth, coherent sine wave indicating optimal sympathetic and parasympathetic balance. Anxiety causes sympathetic overdrive, which can cause the heart rate to increase. And we know that a resting heart rate greater than 75 is associated with increased cardiac mortality. In terms of again, the heart-brain connection, depression and anxiety can lead to reduced vagal tone, which increases inflammation and increases hypercoagulability, as well as reducing heart rate variability. Reduced vagal tone and reduced heart rate variability is associated with increased cardiac events, including mortality, obesity. It's also associated with insulin resistance, hypertension, heart failure, and peripheral vascular disease. Some of the things that improve heart rate variability include beta blockers can help, SSRIs, cognitive behavioral therapy has been shown to help, a healthy diet, a Mediterranean diet, omega-3 fatty acids, moderate intensity exercise, deep breathing, as well as self-awareness, meditation and prayer have also been shown to improve heart rate variability. In terms of cardiopulmonary of triad 3, the end result of endothelial dysfunction is atheroma propagation, inflammation, which leads to plaque rupture, causing ischemic heart disease, angina, heart failure, cardiac arrhythmias, including sudden cardiac death. So I'm going to switch gears now and talk about the pathophysiology of endothelial dysfunction. ED is usually the initial and earliest event when it comes to vascular disease. It happens before there's any functional or structural changes in the blood vessel. ED can occur in the absence of atherosclerosis when only risk factors are present. ED precedes atherosclerosis and cardiovascular events sometimes by decades. ED occurs when there's a loss of homeostasis, some underlying vascular tone, thrombotic potential, inflammation, oxidation, immune dysfunction, and vessel wall permeability. So endothelium maintains vascular homeostasis by balancing dilatation versus constriction, growth inhibition with growth promotion, balancing antithrombotic to prothrombotic, balancing anti-inflammatory and anti-immune to pro-inflammatory and pro-immune, and balancing antioxidants to pro-oxidants. So this is the blood vessel wall. So the lining of the blood vessel is the intima, and that is where the endothelium lies. So if you were to look at the surface area of the endothelium in an average person, it would cover approximately 3.5 tennis courts. The media is where the smooth muscle cells are, and the adventitia is the fibrous covering of the blood vessel. So vascular disease is basically a result of a correct but chronic and exaggerated response with infinite vascular insults and finite responses, and taking into account also epigenetics. The vascular system is basically an innocent bystander leading to vascular dysfunction, endothelial dysfunction and cardiac dysfunction, and then also vascular smooth muscle cell hypertrophy. So this is these are the infinite insults that can affect endothelium. They can be both biomechanical as well as biochemical. And however, endothelium has only 3 finite responses to these insults, which is inflammation, oxidative stress, and immune dysfunction. And that leads to the endothelial dysfunction and vascular smooth muscle cell hypertrophy. So what are our targets when it comes to preventing and treating endothelial dysfunction? Well, we want to increase the bioavailability of nitric oxide. We want to increase endothelial progenitor cells, and we want to decrease angiotensin II, aldosterone, and endothelin. We want to reduce the infinite insults by managing the top 25 modifiable risk factors. We want to control the 3 finite vascular responses. So these are the top 25 modifiable CHD risk factors, and most of these I'm sure you guys are familiar with: hypertension, dyslipidemia, insulin resistance, obesity, smoking, elevated uric acid, chronic renal disease, elevated fibrinogen, elevated iron, a diet that's high in trans fatty acids and refined carbohydrates, low dietary fish oil, omega-3 fatty acids, low dietary potassium and magnesium with high sodium intake, the presence of inflammation, the presence of oxidative stress, immune dysfunction, poor sleep hygiene, lack of exercise, anxiety, depression, homocysteine and or MTHFR mutations, subclinical hypothyroidism, nutrient deficiencies, including vitamin D and vitamin K, heavy metals, and environmental pollutants. So the next 4 slides are nitric oxide pathways. And it's important for us to understand these in order for us to better target our integrative medicine treatments. So L-arginine is an amino acid that gets converted to nitric oxide vis-a-vis endothelial nitric oxide synthase, which is an enzyme in the endothelium. This enzyme requires cofactors, specifically BH4, folate, and glutathione, to help its metabolism. Now, a arginine analog is called ADMA, and this is a competitive inhibitor of arginine. So when ADMA levels rise, it causes the reduction in nitric oxide. ADMA is broken down through an enzyme called DDAH, and DDAH is an enzyme that's inhibited by proton pump inhibitors and reactive oxygen species. That's why PPIs can actually cause reduction in nitric oxide and endothelial dysfunction. Once nitric oxide is made, it has a very short half-life. So it can be oxidized into peroxynitrite, or it can be reduced into a storage form of nitric oxide. Once nitric oxide is made in the endothelium, it diffuses into the media where the vascular smooth muscle cells are. There, then the nitric oxide stimulates an enzyme called guanylene cyclase to convert GDP into cyclic GMP. Now, GMP is a phosphodiesterase inhibitor, kind of like Viagra and Levitra. And what it does, it inhibits the enzyme PDE, which it breaks down cyclic AMP. And so basically, nitric oxide leads to an increase in cyclic AMP. In addition, atrial natriuretic factor, or ANF, also stimulates guanylene cyclase to increase cyclic GMP and thereby increasing cyclic AMP. And prostaglandins also stimulate an enzyme called adenylate cyclase, which converts the energy unit ATP into cyclic AMP. So once nitric oxide is made, it can become oxidized into peroxynitrate. And when you have oxidized nitric oxide, it's not a good thing. It oxidizes LDL and all these other molecules, as well as inhibiting prostacyclin synthase, thereby reducing prostaglandin. And this basically leads to vasoconstriction and hypertension. So you can prevent the oxidation of nitric oxide with antioxidants, including superoxide dismutase, vitamin C, and vitamin E. Again, this is a slide showing how inflammation can lead to increase in reactive oxygen species, and that is a bad player here. Inhibits that enzyme DDAH, which then increases ADMA, which can lead to reduced nitric oxide production. Also, the reactive oxygen species can increase conversion of arginine into ADMA, and it can also break arginine down so it's no longer available for eNOS. Also, reactive oxygen species can break down BH4 into an inactive form, which is a cofactor for eNOS. So cyclic AMP is a good player, and it mediates the effects of nitric oxide and basically causes all the good things that nitric oxide does for endothelium, including vasodilatation, reducing endothelial and vascular permeability, reducing monocyte and leukocyte adhesion, reducing vascular smooth muscle cell hypertrophy, proliferation, growth, and migratory response, reducing thrombosis and platelet activation, reducing the oxidative stress, reducing oxidized LDL, inflammation, immune vascular dysfunction, improving insulin resistance, and reducing atherosclerosis. So the bad player is this arginine analog, ADMA, and inhibits endothelial nitric oxide synthase and reduces nitric oxide. And again, this is elevated in the presence of proton pump inhibitors, also in the presence of diabetes, chronic renal disease, smokers, dyslipidemia, elevated homocysteine, and oxidized LDL. And actually, you can actually measure ADMA, and a normal measurement is 1.0 plus or minus 0.1 micromoles per liter. So you can actually titrate your therapies for endothelial dysfunction based on ADMA. So, so our goal in treating endothelial dysfunction is to balance the vascular endothelial vascular biology scale by increasing vasodilatation, decreasing endothelial cell permeability, reducing inflammation, oxidative stress, and immune dysfunction. We want to increase eNOS and nitric oxide, and there's lots of ways you can do that. I have them for you on this slide: oral nitrates, beetroot juice extracts, polyphenols, vitamin C, PDE inhibitors, glutathione, whey protein, curcumin, quercetin. Those are also very helpful. Also, a mouthwash can actually reduce nitric oxide vis-a-vis getting rid of the healthy bacteria in our mouth. That is helpful in increasing nitric oxide. Also, we want to lower ADMA and increase DDAH activity, and these are some ways you can do that by lowering sugar, controlling homocysteine, LDL. Some of these medications can also do that. Exercise can do that by increasing endothelial progenitor cells, which actually repair the endothelium. Also, stopping the PPIs and smoking cessation. We can also target prostaglandin by increasing prostaglandin, and we do that by stopping the COX inhibitors, including NSAIDs. We can increase ATP by taking CoQ10 and magnesium and some B vitamins and nicotinamide. So again, affecting the mitochondria. We can also increase adenylate cyclase with beta stimulation with exercise and caffeine. We can increase the atrial natriuretic factor also with exercise and beta stimulation. We want to reduce the superoxide anions and oxidative stress by reducing NADPH oxidase, which can be inhibited with antioxidants like N-acetylcysteine, resveratrol, and some of the angiotensin receptor blockers. We can also increase nitric oxide and lower calcium influx with calcium channel blockers. And we can also increase nitric oxide and bradykinin, as well as angiotensin 1,7, which is a vasodilator, with angiotensin converting enzyme inhibitors and angiotensin receptor blockers. Just a few words about statins. So statins do have pleiotropic effects in addition to lowering cholesterol, and these are associated with improved endothelial function. Statins protect endothelial cells from oxidative stress and from LDL becoming oxidized, also reducing other reactive oxygen species. Statins promote progenitor endothelial cell proliferation, which helps heal endothelial cells. Statins also reduce inflammation. They inhibit vascular smooth muscle cell migration, proliferation. They inhibit platelet aggregation and activation. And statins are proven in randomized trials for both the primary and secondary prevention of cardiovascular events. So what are some of the clinical non-invasive ways for us to detect endothelial dysfunction? There's an approved FDA device called EndoPat, and it actually assesses endothelial dysfunction by comparing the blood vessel response before and after a blood pressure cuff is inflated in the arm. I don't have any personal experience with this. Maybe Andy does, but we can talk about that later. I do a lot of calcium, coronary calcium scoring, as well as carotid duplex. The important thing for us to remember is that coronary heart disease is initially an extraluminal disease, and you want to try to find the disease when it's extraluminal and be aggressive in terms of preventive strategy, because by treating this disease early is when you're going to get the best outcomes in terms of slowing progression and preventing cardiovascular events. So this is an interesting slide because it shows us how you can have mild. If you look at the first picture, you have mild extraluminal atheroma, which is the gray dotted area, but the actual lumen is normal size. And then if you look at the second picture, this is when we see moderate extraluminal atheromas. They're actually plaque in the artery wall, but the lumen itself is normal. So when we do a carotid duplex, we're actually looking for the first picture, which is carotid intimal thickening, which is a sign that there's already endothelial dysfunction. When we do a calcium score, we're actually looking at the plaque in the artery wall, not necessarily causing a reduction in lumen size. Because if you look at the third picture, that's when you have severe extraluminal and intraluminal atheroma. These are the patients who are usually symptomatic with angina or arrhythmias or heart failure. And if you look at the numbers, 99% of patients have either mild or moderate extraluminal atheroma, and a very small percentage have actual severe luminal narrowing. And it's interesting because almost 70% of all MIs occur in arteries that have less than 50% narrowing. So arteries that don't have the severe lumen stenosis. 15% occur in the patients in the arteries that do have significant lumen stenosis. And what's also interesting is that 62% of men, their first symptom of heart disease is an MI, meaning that one of these plaques will rupture before they ever become severe. And when they rupture, they become severe overnight, causing a heart attack without warning symptoms of angina. And in 46% of women, the same thing happens. So that's why it's so important for us to identify atheroma earlier on with either carotid intimal testing or calcium scores before we get to the severe narrowing. So just a few words about nitric oxide and hypertension. So all these things we've talked about already, the nitrates, arginine, aged garlic extract, CoQ10, they all improve endothelial vasodilatation by stimulating eNOS. So we can also increase nitric oxide with medications. So we talked about some of these already. The angiotensin converting enzyme, it increases bradykinin. Nitric oxide reduces oxygen-free radicals, also reduces endothelin. Calcium channel blockers, again, increase nitric oxide, reduce reactive oxygen species, reduces endothelin, which is a vasoconstrictor. Angiotensin receptor blockers, again, increase bradykinin, increase nitric oxide, reduce reactive oxygen species. Now, so most beta blockers and diuretics do not increase nitric oxide, with 3 exceptions: nebivolol, carvedilol, and indapamide. Nebivolol and carvedilol are beta blockers that have been shown to increase nitric oxide and improve endothelial health. And the only diuretic is indapamide, which is probably neutral and definitely doesn't make endothelial health worse. Spironolactone and eplerenone, which are aldosterone blockers, are also thought to be neutral. Estrogen increases eNOS, exercise increases eNOS, antioxidants, such as superoxide dismutase, as well as antioxidants that block NADPH oxidase are also very helpful. And again, we want to reduce ADMA and increase DDA activity with the things we talked about before. So the next 3 slides are just basically a laundry list of treatments for endothelial dysfunction. We start with lifestyle and diet, so the Mediterranean diet, the DASH diet. Also restricting calories, maybe eating smaller meals, or even intermittent fasting. I'm actually a proponent of. Vitamin C is an antioxidant. Vitamin K2 is interesting. Vitamin K2, there is some data showing it actually reduces calcification of the coronary arteries. Antioxidants like dark chocolate and green tea, as well as red wine, are good for endothelial function. Quercetin and curcumin are anti-inflammatory agents. Low sodium diet, that's high in potassium and magnesium. Beetroot juice is also good for improving endothelial health. Pomegranate seeds, BH4 and methylfolate are helpful. Molecules that increase glutathione, which is a cofactor for eNOS, things like N-acetylcysteine, whey protein, and nicotinamide, lipoic acid are also helpful. Transveratol is an anti-inflammatory, as is omega-3 fatty acids, fish oils. Again, lifestyle with exercise is very helpful, important, because we know that exercise increases shear forces, which increases eNOS activity. Getting a good night's sleep is helpful, at least 8 hours, and managing stress with either mind-body approaches or exercise, meditation, yoga, those kinds of things. Plant sterols are helpful. I'm a big fan of vitamin D. Aged garlic extract or Kyolic has also been shown to actually reverse calcification of the arteries. It's also good to treat high blood pressure and improves endothelial function. CoQ10 is an anti-inflammatory, it's an antioxidant. I like berberine because berberine improves insulin resistance, but it's also been shown to reduce cholesterol. And it does that vis-a-vis PCSK9 inhibitors. Inhibits that same enzyme that those drugs inhibit, the newer injectable ones, but it's a natural form. And in terms of the pharmacologic medicines that are on the market now, ACEs and ARBs improve endothelial health. Amlodipine, which is a calcium channel blocker, does the same. Statins, again, have a real role to play when it comes to improving endothelial health. Metformin reduces insulin resistance. Colchicine, I don't use much of colchicine, but it is a potent anti-inflammatory. There's data to show it improves endothelial function. and endothelial health. And Modifiable, which is a beta blocker that actually increases nitric oxide. So just to finish up and circle back to our case study. So this woman, we want to make sure that she has, she works on her lifestyle. So, the low glycemic index Mediterranean diet. We want her to exercise. We want her to lose weight. We want her to try some contemplative therapies. These are yoga, meditation, Tai Chi, Qigong. We want to make sure she has good sleep hygiene. I'm sure there's, in terms of nutraceuticals, in terms of her flat cortisol curve, I'm sure Andy has ideas on how to manage that. But in terms of endothelial dysfunction, reducing oxidative stress, inflammation, immune dysregulation, things like vitamin C, curcumin, vitamin D if she's deficient. Interesting, I read this article about COVID patients, and what they found was that there was a higher risk of them having low vitamin D than patients who didn't have COVID. So does it mean taking vitamin D prevents COVID? I'm not sure, but there is data to show that patients who have COVID tend to have lower vitamin D levels. Also, fish oil, CoQ10, beetroot juice, aged garlic extract, which she would benefit from. Now, red yeast rice is a Chinese herb, which is a statin derivative. So if someone doesn't want to take a statin just because it's a pharmaceutical, may want to consider red yeast rice because it has the same endothelial benefits as a statin potentially. Melatonin is actually good for sleep and for blood pressure. Berberine we talked about. And this woman would probably also benefit from treating her blood pressure either with an angiotensin receptor blocker, calcium channel blocker, probably a low dose statin, especially, we didn't talk about whether she hasn't had a calcium score done, but if that was elevated, I would consider a low dose statin. Metformin would be helpful for insulin resistance as well as lifestyle. And we can consider colchicine and Modifiable. So that's all I have. Thank you. I know I threw a lot at you guys.
This is great. Thank you so much. For everyone who doesn't realize, you just attended a functional medicine conference presentation here with all this stuff Dr. Sheth said. That functional medicine is really looking at the root cause of heart disease, vascular disease. We have some time, I think, for questions. Yeah, we do. We have plenty of time. We can start with Joe's question. Great to see you here, Joe. Joe had a question on intermittent fasting and how that is, how have you found that to be helpful both personally and in the research with regards to endothelial health?
So that's a great question. So I'm not sure of how much data there is with intermittent fasting and endothelial health, but I do know it is good for. I personally do intermittent fasting. I try to eat. Originally I started a 8-hour window, noon to 8 p.m. where I would eat, and we try to eat obviously healthy meals, at least 2 meals, and then I was gradually able to get my window down to between 4 and 8 p.m. And right now I just eat 1 meal a day between 4 and 8 p.m. But it's a healthy meal it's got enough calories, and it helps me maintain my weight. And I still exercise, but I was able to lose significant amounts of weight. And by losing weight, I was able to improve my insulin resistance, which also helps improve endothelial health. And also I was able to, get my blood pressure lower, which also improves endothelial health. Also, I think my gut is definitely better too, because it's not seeing all those, can you guys still hear me?
Yeah. Okay.
Yeah. So, again, Andy can talk about this, but in terms of gut health, but my experience is that by eating 1 meal a day, my gut health is much better, which lowers inflammation in my body in general. So I think the benefits of intermittent fasting have to do with better blood sugar control, weight loss, better blood pressure control, and all that indirectly affects endothelial health.
So you start eating at what time?
So again, not everybody can do this. I don't recommend this for everybody. It took me a long time to get to this place, but I usually eat between 4 p.m. and 8 p.m.
Okay, so you're doing 1 meal a day, and you're drinking water and broth and everything.
Lots of fluids. I'm drinking green tea. I'll have black coffee in the morning, and I'm always sipping water during the day.
So you're on the pro version of the intermittent fasting. I think most people start out with skipping meals skipping snacks and doing 3 meals a day and no snacks, and then going to 12 and 12, where it's 12 hours eating, like maybe an 8 a.m. to 8 p.m. window, and then 12 hours off. And then a lot of times people go to 16-8 or 18-6. But so I do think that there is the question for everyone here: would you want to do a class or a group visit on the benefits of fasting, and just put that in chat box if you're interested in that, and maybe we can talk further, Viral, about doing that kind of session. Now, intermittent fasting also reduces metabolic endotoxemia, which basically means there's not going to be the food antigens that are not digested that are getting through to the leaky gut to the bloodstream. They're not going to be a lot of the toxins and other bacterial products like lipopolysaccharide that are going to be essentially causing oxidation of LDL in the endothelium. So I think intermittent fasting also provides the blood vessel a break, so to speak, as you were saying, not as much inflammatory response to have the macrophages start to oxidize LDL, turn into foam cells. So there's probably something that's happening there. It would be really interesting to see. I'm kind of curious about too. I know I don't know if people ask this. There's a lot of questions here. One question I have is where are you on the nutrition part in terms of animal protein, plant protein, animal, like omnivore, plant-based? What's your thoughts for heart health? I know that's like a very broad question, but I feel like that's a very relevant question for cardiology.
So, I think saturated fats in the form of red meat that's high in saturated fat is not healthy for a variety of reasons, but also it does affect your cholesterol, especially the LDL cholesterol. And so LDL cholesterol, if that increases as a result of a high saturated fat diet, it creates more particle numbers, and those particle numbers have a greater tendency to penetrate into the endothelium and become oxidized and develop into foam cells and plaque formation. I think a plant-based diet is amazing. You're talking about healthy fats like olive oil, nuts, avocados, and staying away from the animal fats. I think it's a good idea.
Yeah, and I think not everyone can do that, but certainly eating more plants we know is a good thing. Associated with longevity in the blue zone studies and everything.
And there are healthy lean meats. Like game meat is healthy because it's very lean. And fish is obviously it's very healthy for us as well. So.
Yeah, thank you. Let's see. Another question is on light and sauna, light therapy and sauna therapy. Any data on that? I guess one thing is that we know that sauna does increase nitric oxide. Red light therapy does increase nitric oxide. So in theory, that could help heart health. Mm-hmm. I don't know how much data there is on that specifically for heart health. I'll have to look that up.
I don't know, but I do know that sauna has been shown to, especially in some of the Nordic countries, because they do a lot of sauna there.
Yes.
There's actually outcomes data in terms of reducing heart attacks and strokes. So whether it's from nitric oxide, whether it's just from sweating and releasing all those toxins, it's unclear the etiology.
I think the toxin release is key with the sauna. We've had a lot of people have heavy metal toxicity, which alone, lead and mercury, can cause cardiovascular disease through that infinite insults pathway you were saying in the functional medicine slide. And sauna is one of the ways, because some things you can excrete through the urine and stool and everything, but others you have to sweat out. So that's another piece of it. Yeah, red light therapy, sauna. Araceli, if you have any other thoughts on this, because I know Araceli is on here, I believe, for red light. Just let us know here. Thank you. Let's see. How often should nitric oxide be measured for monitoring? In other words, if you're, there are salivary nitric oxide test strips. I mean, there's all that. So I don't know if you do that in your practice or
no,
things.
I don't. Do you measure ADMA? Have you done that?
No, I know it can be done on like a Cleveland Heart Lab and things, but I do measure this. I actually have this here handily. This is a nitric oxide indicator strip. So there's salivary strips, and you can measure. You can kind of see low, medium, high, and people's NOS activities do go down over time. So that's something that can be associated with heart conditions, including hypertension, etc. So I mean that is something, but ADMA, yeah, I mean I think it could be useful.
Do you have any experience with Endopat?
I haven't, because we do use autonomic nervous system testing here using photoplasmography to estimate HRV and endothelial dysfunction that way, and then we if there's endothelial dysfunction, we'll look at low NO at that point. We'll
Okay.
try to treat that either with
Sure.
medications like ARB, ACE inhibitors,
Mm-hmm.
CCBs, but also with some of the other natural treatments that you said, and the beetroot extracts, things
Yep.
like that. This is a good question. Thank you. This is a good question from Robin. How to treat a poor response on the coronary calcium score? I'm assuming that means if someone has a medium to high risk, on the coronary calcium score, how would you treat that naturally?
Sure. So, we talked about some of those things. Actually, lifestyle is so important. Nutrition, low inflammatory diet, exercise is also important in terms of increasing nitric oxide. But also, things like red yeast rice, which is a natural statin, can also help reduce, plaque burden potentially if you respond in terms of LDL lowering. Also, we talked about that vitamin K2. There is some data with that showing reduction in coronary calcification. Now, there is in terms of conventional approaches, there is significant data showing that if you can drop someone's LDL with a statin below 70, you can actually see regression of plaque. And that's really the only thing that's ever shown regression of plaque, is getting someone's LDL cholesterol down below 70 with a statin.
Part of that might be more of a plant-based diet too, or more vegetables. It seems to be also associated in the Dean Ornish studies.
Yes,
It seems
correct.
to be that can be reversal of COD with the Dean Ornish kind of plan. Meditation, yoga, community support, plant-based diet. I asked this one question because I feel like this is important for our audience here. Women and men do present with coronary artery disease differently. And I think we know from like IVUS, type of studies that you can have a normal intravascular ultrasound, but then women may have more microcirculatory dysfunction, meaning like the cardiac cath is clean, but then there's some, can you comment on that, please? Thanks.
Yeah, so that is, so sometimes we'll see that in women who have coronary spasm. So you do the angiogram and the artery looks normal, but the endothelium is highly dysfunctional, and it causes there's not enough nitric oxide being transported into the media, and the smooth muscle in the media becomes highly dysfunctional and will contract, and that can cause angina, and that can be actually quite severe. And there's a condition called broken heart syndrome, where if you get so stressed out, you get such severe spasm, it can actually lead to heart failure. So again, the whole microvascular dysfunction, I think, is similar to endothelial dysfunction. So I think if you can manage, if you can increase nitric oxide and do all the things that we talked about before, it can help. Just so you know, if you have normal coronary arteries and you have microvascular disease and angina, your prognosis is very good. You're not going to die of a heart attack. And a lot of times these symptoms improve. Sometimes they're hormonal. Sometimes they just improve with lifestyle. And there are treatments, there are prescription medications that can also help with symptoms of angina in the presence of normal coronaries.
Another thing I'll say about thank you. And another thing I'll say about the body composition analysis using a BIA, like an M-body. This is validated at Johns Hopkins Cleveland Clinic. It's something that we use here to check for visceral fat, especially. We know that visceral fat is the primary driver of insulin resistance, inflammation, and heart disease. I think it's something that could be another piece, along with coronary CT, the lipid panel, basic panel, advanced panel, and then a body impedance analysis to look at someone's metabolic health, because that's going to be huge for heart health as well. Okay, so this is a great question from Audrey. Thank you for this question, Audrey. How much exercise actually makes a difference? I don't know if that's you want to take that.
Yeah, so for some reason the number 10,000 steps a day has popped up as everyone's goal, but the reality is you really don't need that many. You really need maybe between 5,000 and 6,000 steps a day to improve cardiovascular endothelial health. That's really where the science is right now. If you want to lose weight, though, that's a different story. So weight maintenance, I would say 5,000 to 6,000 steps a day. But for weight loss, you need to do more. You need to do about, I would say, an hour to an hour and a half of some type of cardio a day. And also, restricting your calories at the same time. You know, weight loss is 80% nutrition, 20% exercise.
Yeah, I agree. It's definitely more nutrition, but exercise plays a role because it can help the insulin sensitivity. Thank you. That's good to know about the steps. Ann says, and I think you know, a son-in-law in his early 30s is having high blood pressure and angina. Very concerned. I mean, I would definitely refer him to a cardiologist like Dr. Sheth here. So, any other comments about that, Viral? I mean, probably needs to see someone for sure.
Yeah,
though.
no, absolutely. A young person who has hypertension, you know, 9 times out of 10,
Mhm.
hypertension is genetic. So if there's a family
Mhm.
history of hypertension, most likely. But then there are also, you know, lifestyle issues. You know, I don't know if he's obese, if he you know, adds a lot of salt in his food, he's sedentary. So you can change all that around. But also there are secondary causes of hypertension that can actually be treated. Things like renal artery stenosis, meaning narrowing of the kidney arteries, or some hormonal abnormalities, such as hyperaldosteronism. So there are some things in a young person that can lead to hypertension that you don't see in older folks. But 9 times out of 10 is genetic or it's lifestyle.
Okay, she did mention one other question to follow up here that I just looked at. What tests would you advise for the 30-year-old having the high blood pressure and angina that a traditional cardiologist might not recommend?
So I would definitely you know, do a calcium score to see if there is any and even a carotid ultrasound, looking to see if there are signs of endothelial dysfunction. As a 30-year-old, I mean, if they're having chest pain, it might just be because the blood pressure is uncontrolled, not because they have blockages or endothelial. You know, so the goal there would be to get that blood pressure under control, look at their metabolic profile, and look to see if there are signs of endothelial dysfunction.
We would also check the vital scan that's looking at the autonomic nervous system, HRV, and that can also look at endothelial function, arterial stiffness. That's great. Oh, can you do a sauna if you have sleep apnea and AFib? I don't know that it would be a contraindication, but as long as you're
I would
hydrated, I
definitely
guess.
make sure they don't fall asleep in the sauna.
Right, right. Make sure that OSA is more controlled. Absolutely. Awesome. Okay, the fasting is good. Yeah. Which fish oils? Wendell asked. Hey Wendell, which fish oils do you recommend? Or fish oils, and then we know for vegetarians you can do like things like algae oil,
So that, you know,
etc.
this is where integrative and conventional medicine kind of overlap. There is a prescription fish oil, Loveza, and I forget the other one.
Yeah.
They're pure fish oil without any of the mercury, you know, issues. And there's actually now good data and good science with randomized trials showing that those high potency fish oils can actually reduce heart attack risk. So if you really wanted to go by the science, you'd want to use one of the prescription fish oils like Loveza, or I forget the other one. There's another one on the market.
I know what you're talking about. But
Yeah,
the
yeah.
Loveza, isn't it like 2 twice a day? It's kind of this.
It's 4,000 milligrams a day.
4,000 is a lot. Yeah, it's a
Yeah,
fair amount.
yeah, yeah.
4,000 of EPA and DHA, or?
Yeah, I think it's a combination of.
Yeah.
Yeah.
Yeah, because that's a fair amount. So I think from the integrative functional world too, we know that about 3,000 to 4,000 milligrams is needed to get the fish oil or get the omega-3 fatty acids into the cell membrane. That's where another thing, you know, sometimes the dose is too low on some of these other negative trials where it's like, oh, it didn't really help. A lot of times it's like it might just not be enough to get that red blood cell omega-3 level up enough to make a difference.
But I think when you have that pharmaceutical grade, you have pure.
You know what you're getting and stuff. Yeah.
Cost more, but it's, you're getting what you're asking for. So.
Yes. Okay. Another intermittent fasting question from Carmen. Please address gender differences in female cycle difference. Is it effective or helpful? Is IF effective or helpful for perimenopausal women, and probably also for premenopausal women? I would say that would be a good question.
Yeah, I'm not sure about that.
Jen, do you want to chime in on that? I know Jen is talking about that a bit in terms of cycling, carb cycling. Do you mind talking about that?
Yeah, I mean, that's a really big topic that may deserve its own talk.
That's part of, we'll put that on part of the class. I mean, I think you definitely, my understanding of the research on IF is that it's better for menopausal, potentially perimenopausal women and men. For premenopausal women, there may be some issues with the adrenals, hormone imbalances. If someone is stressed out and tired and the cortisol is off, the hormones are off, thyroid's off, and that that might be an issue with intermittent fasting. So you have to address all the factors: the sleep, the stress management, the exercise, the nutrition, all of that. And then when all that's good, then intermittent fasting. But it depends on the person. I really feel like someone with metabolic syndrome, which potentially up to 80–90% of the US has metabolic syndrome, intermittent fasting can be really helpful if all those other factors are addressed as well. Joe is a research guru here as well, putting a lot of studies in the chat box. Prolonged fasting improves endothelial progenitor cell mediated ischemic angiogenesis in mice. Thank you. So some good basic science there. Thanks, Joe. Another nice study. So intermittent fasting may improve microvascular endothelial function in healthy middle-aged subjects. So basically, again, NO bioavailability. I think NO is a big future in both cardiology, integrative primary care, functional medicine. Nitric oxide is something that a lot of doctors don't really, I feel like people just reflexively like, okay, let's treat with a CCB or let's treat with a medication, but not really understanding that it's nitric oxide that's driving, it could be a chicken and egg thing, could be inflammation causing low NO, but also low NO could be causing a lot of vascular inflammation and problems and smooth muscle cell hypertrophy, etc. So I feel like NO is definitely a place where we're going to go more with our practice in terms of trying to increase that with all the lifestyle ways, all the nutraceutical ways, and medications.
When you're measuring NO, Andy, are you seeing treatment lowering and NO levels when you do the salivary NO?
It's pretty basic, and it's not so quantitative. So on this strip, they just have this proprietary depleted, low, and optimal. So it's basically like this color coded, kind of like a UA dipstick, So if this is pink here, it's mean depleted. And then if you go up to magenta, so we'll see people that are taking this though, and they'll lower their blood pressure by 10 points, sometimes 15 points. They'll avoid having to take meds, doing the diet and exercise and doing all that. So that is something we found helpful. We talk more about it. I think that's great. Yeah, this is a very exciting topic. Thank you, Joe, for all the enthusiasm here, research. What about avoiding nightshades when increasing a plant-based diet? That kind of depends on the person. I think 10% of people are sensitive to nightshades. It could cause arthritis, inflammation. I'm not sure what your thoughts are on nightshades.
No thought.
No thought. If you would refer to our nutrition team for sure. Thank you. The nightshades can be an issue for some people. I think as you get the gut more imbalanced, the microbiome, you get the gut inflammation down, you can tolerate more foods. That's part of the things we talk about. This is a little bit of a tangent, but oxalate sensitivity, salicylates, things like that. Some of it could be genetic or epigenetic related, but it could also be related to, is the gut balanced? If the gut's more balanced, a lot of times we're able to tolerate more stuff, more food. Endothelial dysfunction happens decades before a conventional diagnosis of CAD. Therefore, it's helpful to get screening and treatment beforehand. I'm really glad and I feel lucky to have met you through, coming here, visiting us, and just knowing that there's an integrative cardiologist in the area is awesome. Like you, that can do proven research, conventional therapies, innovative, and also potentially research-based integrative functional therapies and lifestyle medicine. So yes, Dr. Sheth, if someone asked, are you offering virtual consults? I don't know the answer to that.
Yeah, we do telemedicine. We do Zoom.
Yeah, and do you take insurance in your practice and
stuff?
stuff?
We do. We absolutely do.
Medicare and insurance and things like that. And the website, I'll put the website on here, cardiocare.com, I think, right? Okay. Is Dr. Sheth's practice. There's many cardiologists in the practice. I know quite a few of them. We're friends with them. I think you're the only integrative cardiologist in the practice. Would you say that's accurate?
Yes.
It's 1 p.m. I know that we are out of time here, but I'd love to have you back for more chat on cardiovascular health. Thank you so much, Viral, so much.
Thank you, Andy. I really appreciate it. Thank you.
Yeah.
Take care.
Okay.
Good day.
Thank
Bye.
you. Thanks, everyone. Bye.